One of the late-breaking clinical trials at AHA this year is the ISAR REACT-4 trial that looked at the in-lab antithrombotic management of NSTEMI patients, a very common scenario. Deepak Bhatt is here and was the discussant for the trial presentation. Do you want to review, I think, the patient population, the two things that were being studied?
Absolutely. So this was a study of non-ST segmental elevation MI patients undergoing PCI who were randomized, about 1,700 of them, to receive in the cath lab either Bivalirudin as monotherapy or heparin plus a 2b3 inhibitor, specifically Abciximab, with a dose of heparin of 70 units per kilogram. So standard contemporary heparin 2b3 versus Bival in a randomized double-blind rigorous design. So a well-designed study to answer an important question that in part had been addressed by Acuity, but this study focused on PCI and NSTEMI, particularly biomarker-positive NSTEMI.
And it really, I think, very clear results that elevates the different therapies. So can you summarize the findings?
Yeah, I agree. I think it's a pretty clear-cut result. It showed that for the overall endpoint, when one lumps together important ischemic and bleeding outcomes, there was no difference. But specifically drilling down on ischemic events, death, large MI, urgent target vessel revascularization, even looking at smaller degrees of myocardial infarction periprocedurally, no significant difference between the two therapies. Whereas for bleeding, major bleeding was reduced by about 4.6 to 2.6%, so a significant absolute and relative risk reduction in major bleeding, no apparent loss of efficacy with Bivalirudin versus the heparin plus Abciximab strategy on a background of aspirin and 600 of clopidogrel. So at least in that setting, to me it seems pretty clear-cut, no loss of efficacy, less bleeding, also better convenience, no need for a longer infusion. Seems like a winning strategy.
Well, this is, I think, a big follow-up trial to Acuity, then double-blind, and really validates this concept of less bleeding done in the lab. This is how it's practiced here at the Brigham, I'd say, of that decision in the lab having gotten whatever they've gotten ahead of time. So a nice, clear result from ISAR REACT-4.
I think so, and it builds upon other studies, as you mentioned, Acuity, but also Horizons that for ST elevation MI and PCI showed similar ischemic outcomes, less bleeding, and as a secondary endpoint, lower mortality with Bivalirudin than a heparin plus 2b3 strategy. So for across the spectrum of ACS in patients undergoing PCI, certainly if they've been pretreated, it appears that Bivalirudin is a good strategy.
Oh, terrific. Well, for CardioSource Video News, I'm Chris Cannon.